So TMJ patients are sometimes complex because they come with a multitude of different symptoms. Sometimes it's very obvious, headaches, jaw pain, clicking, popping, and other times it's something really subtle. And in this case, I had a lady that had basically really no symptoms aside from severe bone loss around a couple of teeth. So on the x-ray, there's like no bone and teeth are mobile, but it's like 2 teeth in her mouth and nobody could figure out what was going on. So this is typical of patients where I think the bite is contributing, but I'm not quite sure, and I just sort of want to take a look and see what they're doing in their mouth on models. So we do scans of their teeth, we 3D print the models, and then we do different types of registrations of their bite, and essentially mount the models on what's called a dental articulator with this bite. And then once everything's set in stone, then we can take the bite out and then take a look and see how this patient looks and where the contacts are in the teeth. So I'm going to show you sort of the basics of diagnosis and the analysis of a bite, and then some ways to treat these conditions. A lot of the times I'll just mark the bite on the initial touch. So this is articulating paper. It has red ink on one side and blue ink on another. And I essentially am just going to like place it between the teeth and do a couple of taps to mimic the patient's bite, and then open it up. And right away, you see contacts very heavy on tooth right there and tooth right there. So if I test it, I'm just going to use a little bit of shim stock, and I can put this in between, and the paper really holds. So I'm just going to go like this. I'm going to try and pull it, it holds. Whereas anywhere else, if I put it, it comes right out. Put it here, it comes right out. So that's a very simple way of knowing that there's a prematurity on this tooth. And oddly enough, this is the tooth with a massive bone loss. Okay, so in this part, I'm just going to simply adjust the prematurities and then recheck again. Okay, so in this case, the prematurity is on the incline of the buccal cusp, got down a bit. And it's also on the palatal of the upper cusp, palatal incline of the upper cusp. So we're going to leave the other contacts in for now. I'll probably end up adjusting more because this tooth is quite heavily in occlusion. And then just recheck it again. So mark it up. And check with shim stock. And we're picking up other contacts now. This is better. Where are we at? Okay, and something here. And she had bone loss on, okay, it's the 7. I have tuck back on shim stock, so I'm going to just adjust that out. And the benefit of mounting our articulators is you can see from behind, and you can see where she's hitting. And again, it's the lingual incline of the 7 here. I'm basically doing the adjusting to see if I can do this in her mouth later on, so if I can duplicate these adjustments without doing a lot of damage to the teeth. Okay, so we're going to test these contacts again. This one now is marking quite heavily on the second molar, and let's see what's happening on this side. And there's an interference here on the 5. So both of these, just going to take a look. So it positions on the centrals. Oh, helps to record. And I'm just going to tap, 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 pretend the patient's tapping, and you can see the heavy contact right on that tooth where there's massive bone loss. And then you can see the other area where there's further massive bone loss. So there's the two contacts that are premature. So we're just going to adjust those. And I can record this. I can take a peek at this again. And bring it back here. And now I've got a visual recording. And we're going to adjust. You can flip it out to show lowers. And we're going to adjust this area and this area. So I've imported the digital scan, and so you can sort of see that where the teeth are, and you can sort of follow along where the interferences are. And the decision is where to adjust, right? Do you adjust on the top or the bottom? I'm always looking at the inclines. If the incline is hitting, then I adjust the incline as opposed to the actual contact. In this case, it was hitting the incline of the lower, and then let's see what's going on the top. This is again the cool thing, you can turn it around and see it from inside. So the upper cusp is hitting the incline. Again, I'm going to take down the incline. And we'll T-scan again. Okay, so now I've got 1-4 and 2-4. So I'm going to mark that one in blue. And 1-4 is the tooth that's got a ton of bone loss as well, and it's actually over erupted. So I'm going to mark that one. And this is on the incline, so we're going to do the cusp again. And obviously we do not want the buccal cusps of the upper bicuspid touching an occlusion, so I'm going to take that right out. And then this side, it's the buccal cusp to buccal cusp contact right there. So I'm just going to take that out as well. We don't want buccal cusps touching. And then we're going to do the front teeth. We do not want her touching on the front just yet. 3-1. I'm going to adjust the lower just because it's a little ragged looking. Alright, let's see where we go now. Picking up some blue contacts and just the front now. And now we're picking up some interferences in the back again, and essentially you kind of keep going back and forth, because as you get one out of the way, another one picks up, and it's kind of a lengthy process sometimes. So now we're on the 4-7. Again. And that buccal cusp, and let's see where that hits. So that hits on the palatal incline. I'm going to just take out the palatal incline there. Oh, cusp incline. And that actually happens tooth tilting, because as we're tipping, because of the missing tooth, that tooth is tipping, which raises the. You really want to sometimes feel it or have the shim stock kind of leave a mark, like a little, yeah, because you can see it. Can you see that line right there? And underneath it tells you it's that cusp right there. So we're going to just tuck that in a bit. And yes, you want the buccal cusp sitting in the fossa, but you don't want it as an interference. Sometimes it's not the big contact that you think it is. You would think it's the obvious one. It's the little interference right there that's hitting in the wrong spot. So look at the difference in the size of this articulating paper mark and then this one. And really, when I pull shim stock, this is the culprit, not that one. So I'm just going to take this one down a tiny bit. So I don't necessarily have to finish her on the models because we're going to do this in her mouth. As long as I know I'm getting some contacts kind of sporadically or balanced throughout the mouth, I can go and switch to the lateral movements. So we're going to basically unlock. She's still a little bit heavy in the front, but I'm going to wait on that. So we're just going to unlock the side here, and one side at a time, and just basically look at lateral movements. And you want canine guidance, right? So she's hitting really heavy on that tooth that she's losing bone on the 1-4. So I'm just gonna mark it, and we basically wanna build her into canine rise. And I'm not sure if that's gonna be possible without some management of the 1-4, because there's probably gonna be some damage to it. Let's just see. So, same thing, just making lateral movements. Mark up that slide. And then I'm literally just going to take out that buccal cusp and reshape it. It's hard adjusting it sitting down. The tooth is so over-erected that I have a feeling we're going to have to be, I'm going to be like through enamel and having to do some sort of a restoration to restore. So we're getting close on the canine. So if you look on the lateral movement, we're almost there on the canine. So I might be okay, and manage to get into canine rise very quickly. But definitely at this point, I removed enough enamel that I would have to restore in some way. And so this is the other thing, is that I probably won't be adjusting the lower anymore because I already know I'm going to be rebuilding this tooth. So we might as well do the majority of the adjustments in that as opposed to exposing 2 teeth to invasive treatment. So I'm going to take this one right down, knowing that she's going to need to have some sort of maybe an onlay to cover up that cusp from being so exposed. So let's see. Did we clear? Yeah, she's fully on the canine. So I always verify with shim stock. It felt like maybe there was a cusp hitting on the lingual, but I think I'm good. I can feel it. I can feel a tug. So that's a palatal cusp on a lateral slide. And that's significant. That can also cause a lot of symptoms. So always double check, because I could feel a tug here, see? And that's right on the bicuspid. So it's marking on the palatal cusp. So again, this tooth could be adjusted. I'm going to adjust this one because we're already covering it up with some sort of porcelain restoration. Okay, let's try that again. Let's make sure it goes with shim stock. There should be no contact on that bicuspid in a slide, and there still is when she comes over. Now the likelihood of her coming over that far is low, but we're already doing it, might as well, right? That way we can reshape that tooth into ideal position. So I'm just going to take out that buccal cusp completely here. And we're fully on the canine, and everything else is free. So this side is good. We're going to switch sides and do lateral movements on the other side now. And again, I'm looking for canine which I'm not gonna get on this side whatsoever because the canine's super far away. So the challenge is gonna be, do I leave her in group function of some sort, or do I restore? And that's something I can talk to her about. But this tooth and this tooth still have that significant bone loss, so I am gonna adjust them partially just to get them out of the imminent bone loss issue. And then I can talk to the patient to see if she is interested in restoring further. Okay. You have to really remember to go back to occlusion from our early days in school, because if you just adjusted that buccal cusp on the lower, you'd be adjusting the wrong tooth, right? Because you want to keep that one in occlusion when she bites down, but you want it to clear on lateral slides. So, and the upper cusps are not supposed to be in occlusion, so we're going to make sure that the upper is clear. And that one's clear. So, lingual cusp of the lower molar is interfering with that slide. You can see that there's like a slide on there. We don't want that slide. We actually don't want lingual cusp hitting on the lowers, but I am going to tuck in that palatal a tiny bit. Okay, so let's check that out again. Shim stock is thinner than articulating paper, so it's a really good medium to find where you're getting stuck, because articulating paper can sometimes mark so much, but somewhere right in this movement I'm getting stuck. So what is that? Looks like the marginal ridge of that 6, and that's the tooth that's also having significant bone loss in this area. So I'm just going to reshape that, tuck that in, get the buccal cusp out of the way. 7s are actually very, very common for us to see in terms of pain on slides, because a lot of people don't check for lateral slides and buccal cusp interferences. So that's a really common tooth pain issue. Really common bite adjustment here. And now I'm clearing up all of them. So all the adjustments so far, except for the one tooth that we're going to be doing porcelain only on, have been very conservative and minor. So there's no need to do any dental work on her on anything but that one tooth. It's front teeth. Okay. So in order to get her on the canine here, we have to reduce in the front, because she's driving sideways on that front tooth. So I am going to adjust it down a bit more, because I do see the potential of putting her canine guidance here, which would be lovely. So let's see where we're driving this car. So she's hitting, when on the slide, right on the insides of the uppers, and we don't want to reshape those. I know she's gonna want to keep her uppers the way they are, so I'm going to reshape the lower and just tuck it in a bit. Most people actually don't like their lower teeth and want to make them more even. A lot of the times you see chipping and wear and all that. So a lot of the times in equilibration, you actually end up adjusting these guys to better shape than before. So most patients don't mind me grinding the lowers a little bit if I have to. Normally I wouldn't grind the lowers, I would actually want to open her up, but she is very open and compared to her ideal vertical. So she actually does need to close up a little bit more still, which is why we're doing the equilibration. She's still heavy on the front teeth. Do I have any hope of getting her on the canine anytime soon? No. She's now back onto the bicuspids. So this is gonna get into a more intense equilibration with her. Yeah, and now I'm on the cusps again. So I'm picking up lots of interferences on these teeth. Figure out, you know, how far, or what will it take to get her to where you want. And if you can't do it, at least you've done it on the models, and then you can talk to the patient about it and see if they want to go that far, or if we need to open her up a little bit. Now, because she's about 2 millimeters too open, I have a lot of room, and I have a feeling, I want to do this exercise and have a chat with her, but I have a feeling she will actually prefer the equilibration and the odd restoration that needs to be done to restore her teeth over opening up the vertical. So she also doesn't have any TMJ symptoms. She doesn't have any headaches. The only thing she's got is the bone loss. So I think even if we had to do a couple of restorations in the bottom teeth, or a couple of more teeth, she would much prefer that over a full arch, or a full mouth and orthotics and things like that. So I'm gonna keep going just to kind of figure out how far it'll take to get her balanced, and then I can talk to her about it intelligently and basically say, yeah, to get you there, you're probably looking at a couple of crowns, or 3 crowns, or 4 crowns, whatever. So I'm now going to go back to my full arch paper, because at this point we're kind of marking everything, and I want to see where she's like really grinding. So again, front teeth or buccal cusps. And by the way, notice the little setup that we do so that you have access to lots of other extra paper. The wrapped one has Vaseline on it, so it marks really well. These are not coated with Vaseline. Q-tips in here, and then additional shim stock so that I can just grab some as I need it. So we do that with every adjustment. Every operatory has one of these. So anytime I need to kind of, because we go through so much articulating paper in this office, it's ridiculous. Okay, I'm on the canine. We did it. Now it's kind of a crappy spot, but would have liked to see it in a different position, but we're there. So let's see how the front feels. So she's hitting on the central here and on the canine. So the question is, will she go that far? And I'm going to test it, but I probably won't adjust here because there's no point. The likelihood of her going that far is low. And additionally, I have a feeling that she will be very happy to wear a night guard after all this. So she can expect to have an onlay on this tooth on the 1-4, a bunch of little adjustments on the front if she gets sensitive, and I'll let her know that we may need to cover them up in one way or another. The other adjustments were really minor, so I don't anticipate too much going on, but I might want to redo the 2-6 crown. So it's something that obviously I'll talk to her about. Which contact was I feeling? Another way to check with shim stock, if you've got like say 3, 4, 5 contacts you're not sure about, you position the shim stock just over the one contact. So just the tip of it over that distal buccal cusp, and then it comes out. So you know it's not that last cusp. So you know it's not this cusp when I test this cusp. So now again, I'm just gonna slightly cover that one spot, and I felt a tug. I really felt a big tug, okay? So we know it's that one. Not a fan again of inclines. So we're gonna take that out and create a groove for that upper to kind of slide into. And you're gonna leave the contact. You wanna leave this little tiny contact. That cusp should be in occlusion with the central fossa here. We just wanna take out the incline. For those of you who like occlusion, this is heaven. For those of you who don't, you're gonna struggle because some of these adjustments can take a really long time. Sometimes we're half a day before we're done with a patient. Okay, so there's a tug here, and again, which contact is it, right? There's 3 that it could be. So I'm gonna test it with shim stock. I suspect it's that distal, but let's just, for fun, kind of check all of them. So you're gonna go distal buccal, comes right through. Mesial buccal, comes right through. Okay, let's see. Good contact there, good contact there, good contact there. Good contact there. Okay, so let's make sure the front teeth are not touching. And she's got a class 3 tendency anyways, right? So no wonder she's here, and I have a feeling she'll actually even come forward a little bit more, which is kind of a concern. But okay, so I've got no contact on the right side. So then the question is, and she's got solid something there. So the question now becomes, as you do this, right, what's her vertical? So let's see where she's hitting first, because if I've overclosed her, then I'll need to open her up. Where's that contact? I'm just gonna measure real quick. So I've equilibrated her to 1904. So that is exactly her ideal vertical anyway. So we're pretty much there. The challenge is always with the fact that if I reduce on her, let's say I have another 0.5 millimeter to reduce. If I reduce on her to a point where I'm exposing dentin, then I have to restore. And if I have to restore, then I'm restoring some or all of the teeth involved. The other thing is she may not be able to tolerate the closure. She may actually get into headaches and TMJ issues. So once you get past the golden vertical and you close a patient, some of them do really well and some of them don't. So then we have to open them up. So then it kind of like opens up a whole can of worms, because you've got the challenge of, do I close her up and take my chances, or do I leave her at the golden and then just consider restoring some of these teeth, because we would have had to restore the other side if I were to close her up. So conservatively speaking, the simplest thing to do right here would be to stop and basically say to the patient, you know, if I keep going to adjust down here, there's two issues, right? One is that I may have to, by exposing dentin, I may have to restore some or all of those teeth. And number two is you may not tolerate the vertical closure, and you may actually end up with other symptoms like headaches, pain, neck pain, tension, things like that, clicking or popping. So is it worth trying to equilibrate you down and hope, or would it make more sense, since we would have to restore the side anyways, to just raise this side to this vertical right now by restoring a few of these teeth? And frankly, that would be a much more conservative way to go. Just raise a couple of these. So that's what I'm going to talk to the patient about, and then we'll see what she decides. Thanks for watching.